Hello and welcome to Talk of Hope, a podcast for people affected by lung cancer. I'm Rachel Avery.
And I'm Yvonne Diaz.
Each episode we'll hear from people with different experiences of lung cancer, as well as healthcare professionals who will share what's going on to improve the diagnosis and treatment of this disease.
As someone who has lung cancer, I know exactly how terrifying it can be. But amongst all that fear and anxiety, there is also hope. And that's what we're choosing to focus on here.
Now, for the regular listeners to Talk of Hope, you'll notice we're missing Mandy today. But instead, I have the pleasure of hosting today's show with Yvonne Diaz. Yvonne is living with stage 4 ALK-positive lung cancer after being diagnosed back in 2021. And she's the perfect co-host because she's actually gone through what we're about to talk about today. Back at the end of May, it was announced that NHS England are to roll out a pioneering blood test that could transform lung cancer treatment. Liquid biopsy is a cutting-edge blood test that identifies fragments of tumour DNA circulating in the bloodstream and enables doctors to detect genetic mutations and quickly determine whether a patient is eligible for targeted therapies. What's more, an NHS pilot has seen patients starting treatment up to 16 days earlier when using a liquid biopsy compared to traditional tissue sampling. And I know, Yvonne, you were able to start your treatment quicker because you had a liquid biopsy. Also joining us to explain more about this exciting step forward and what it could mean for people with lung cancer is Professor Alastair Greystoke, co-clinical lead of the ctDNA pilot and honorary medical oncologist at Newcastle's Northern Cancer Centre for Cancer Care. Welcome, Alastair, and welcome, Yvonne.
Thank you very much. I'm very pleased to be here.
Oh, we're delighted to have you. Now, that was a very, very long intro that I tripped over a couple of times, but I'm just gonna ignore that happened, and these things do. But no, thank you both for being here, Yvonne. Thank you for stepping into Mandy's shoes, and as I said at the beginning, it's the perfect one to bring you in on because you've got that first-hand experience. But Alastair, coming to you first. So this news kind of came out at the end of May, liquid biopsies. Can you tell us a little bit more about what that is and what's involved for a patient?
Okay. So from a patient's point of view, it's actually relatively simple. It's a blood test. It's 2 tubes. And in fact, it goes into post, which always slightly confuses my patients. They're like, oh, you're doing this valuable, and it's quite an expensive test, as we'll talk about, and it's just going in Royal Mail. But that's what we do. So this is based on the fact that it's increasingly important, as I'm sure many of your listeners know, to work out the differences between the patient's lung cancer and the rest of the body. Because about half of patients that have lung adenocarcinoma, the most common form of lung cancer, will have something where I may be able to offer them a targeted treatment at some point in their journey, hopefully as their first treatment, sometimes as a second. So traditionally, this was done on a bit of the patient's tumor biopsies, and we were looking at changes in the tumor's DNA between them and the rest of the body. But the technology has got much better, much more sensitive. And we know that patients with lung cancer, particularly when the lung cancer has spread through other parts of the body, they will release small amounts of their DNA into the patient's bloodstream, and it's tiny, okay? So 10, 20 years ago, we couldn't reliably detect this, but the technology's got so much better that we can now do it, as I say, 2 tubes of blood off in the post, and then I get an email back 2 weeks later hopefully with the patient's tumor profile, which they can then use to guide their treatment.
It's it's kind of crazy, like you say, that this miraculous little test is very simple for the patient, and off it goes in good old Royal Mail.
Correct.
But it's speeding things up.
Yeah, in fact, I'm afraid you made a mistake in your introduction, but that's maybe in the press release that came out from NHS England. So the reason we managed to get this funded in the National Health Service for patients was for the last 3 or 4 years, we've been working very hard on a pilot where we started off with 700 patients around the country, and then we extended that number slowly out and brought more and more hospital trusts on board. And it was an average of 16 days. There were some patients who got treatment, their treatment was sped up much more quickly than that. And in fact, there were some patients who otherwise probably wouldn't have been able to access treatment, either because we wouldn't have been able to get the right piece of their tumor, or their tumor biopsy would have failed when it went off to the laboratory. So,
Yeah.
sorry.
No, but we'll come on to kind of comparing it to the traditional methods and kind of the benefits for exactly that reason. That those difficult to get to tumours. But Yvonne, just bringing you in, because as I again said in the intro, you had a liquid biopsy. Can you tell us a little bit about your experience?
Yeah, no, it's fascinating to see this coming now to everyone. So as you mentioned earlier, I was diagnosed in August 2021. And and like many people, you just don't expect this is happening to you. It's a whirlwind of scans, all kinds of appointments. And I had a bronchoscopy, and so they went down the throat to try and take some samples. And basically, there was too much necrosis, dead cells. So I was told they had to then repeat the process. And that whole thing was taking a long time, right? And then they scheduled a CT guided lung biopsy. And again, I'm waiting. And then I was called like a week later, told, actually, we do have good cells. We're now going to test them and we'll come back to you. And meanwhile, I was becoming more and more unwell. I was coughing a lot. I had been vomiting all day. And really by then I couldn't even get out of bed. So I was quite unwell, couldn't eat. And then I was offered a blood biopsy as part of the trial. So and it was quite remarkable. Within 10 days, I think, I received the call. It was on a Friday, I'll never forget it. And I was told, we found a biomarker. You have ALK positive lung cancer, and we're going to start treatment on Monday. I had been quite unwell to the point where my oncologist had even scheduled some chemo. We just thought, look, he knew at that moment I might be a candidate with a biomarker, but because of how I was going downhill, he thought we could do maybe a round or two of chemo to help prop me up, as it was put. And that meant the chemo was canceled. I started the right treatment, and really within 7 days of starting that, I started to feel much better. So the whole experience was wonderful. And now knowing that, it's one thing you hear as a patient. So many of us wait so long for this biomarker testing, and it can be really challenging when you are feeling unwell. Not only that, but then you're anxious. Your disease is quite advanced. You want to start the treatment. I didn't even feel safe to tell my children that I had lung cancer because I wanted to tell them what my treatment was. So really, a lot of things were on hold because I was waiting for that diagnosis.
I imagine, yeah. I mean, we've talked about this on a previous podcast about that emotional impact of telling family and telling children. And I remember speaking to one lady who shared her story with us, and she was like, I didn't want to tell my family until I could tell them what the plan was, because it's that reassurance of, yes, this awful thing is happening, but there's a plan. And it's such an important piece of information. And like you say, waiting to get on the right treatment is so important. But an agonizing wait, both physically, as you said, you were very, very ill, but mentally knowing that you have this disease and it is remaining untreated, your mind, I imagine, just went crazy. It went to all the worst case scenarios.
It's seriously so challenging that time. The days feel like weeks, and you're just sitting there in kind of this vacuum. It's pretty terrifying to look for information because you might find the wrong things, and all the statistics out there are pretty scary. So you're also told, don't really search around, like just hang tight. But it's the most challenging time. You're kind of so vulnerable. You're quite disempowered, and you're just waiting for this magical information to kind of show up. But you don't really understand the process either. I don't think it's really clear to patients what's happening when you're undergoing all these tests. You just know one test leads to another test, and it's a whirlwind, right? So you're just submitting yourself into this process and trying not to think, but it's really a most challenging time.
Yeah, you're entering into a complete unknown world. I mean, Alastair, you're surrounded by it day in, day out, as are we at the charity. But when you're when you're first diagnosed, it's a whole new language. It's a brand new world that you never thought you'd ever have to experience. Before the liquid biopsy, now that it's coming in, but before, what was the kind of the current or the previous methods for diagnosing and identifying lung cancer?
Yeah, so Yvonne sort of touched on this. So in general, most patients start with a CT scan, which gives a picture of the whole body. Sometimes have additional scans to assess where the spread has been. But most of these patients, that will be their first sort of port of call, either ordered by the GP, potentially through screening programs now, or because they've attended a hospital feeling unwell. And at that point, the first thing that we've always traditionally used to do was to try to get a bit of the tumour, and it didn't hugely matter where. So about half of patients in the UK, it tends to be by the bronchoscopy, as Yvonne described, under sedation. It's not a general anaesthetic, and some people do find that quite distressing. Having a telescope put down into the lungs and try to either directly take a little bit of the tumour or use an ultrasound probe to try and put a needle into the tumour through a bit of a lung. The other half of the patients, it will be either through a CT guided biopsy, so in a CT scanner with somebody using a very small needle. People get quite worried about this, but actually they are tiny needles, putting it into the lung under local anaesthetic, or sometimes it'll be where the cancer is spread to. So if it's spread to a gland in the neck or potentially to the liver, and again, normally under ultrasound guidance, so some ultrasound jelly, a probe, some local anaesthetic and a little needle in to get the tumour. And then this is where a lot of issues arise, is even once they've got that biopsy, it then needs to go for a series of tests. And that's to determine the type of cancer, ensure that it is lung cancer and what type of lung cancer it is. There's almost 200 types of lung cancer before you even look at the genetics. But then also send it off to a genetics laboratory to look for those DNA changes. And that process, unfortunately, is very clunky in a number of places. A lot of these pathways have evolved over time. So it's not like your Amazon where you put your thing in and you can track what's happening and you get alerts on your email every 5 minutes as to when your package is going to arrive and you get a package. It's not like that. And unfortunately, that then leads to issues, particularly for patients, because they don't know what their tumor is. But also for clinicians, I don't know where that is or when the result is going to come. And that actually causes difficulty for me because I don't know when I should see the patient and plan their treatment, even if I'm going to have to give them chemotherapy or immunotherapy, how I'm going to plan that. So that leads to the uncertainty at a very anxious time. And that can often add to the anxiety and also anger, because I do get people who are angry and say, well, when's my treatment going to start? I'm going downhill. I'm becoming iller. Sometimes often actually the patient's loved ones, because they're saying, well, actually, my loved one's getting worse. When are you going to do something about it?
Yeah, I mean, I actually had a similar experience a couple of years ago. My father-in-law, it wasn't lung cancer. It was, well, they believe it was pancreatic cancer, but he had 4 biopsies. Yeah. And everyone came back inconclusive. So he had to go through that again and again and again. And obviously it slowed everything down. It put immense strain on us as a family, because everyone's frightened. And again, as I said, Yvonne, you want that treatment plan. You want a plan of attack to deal with this and regain a little bit of control, don't you? And that's how we felt. We just felt totally out of control. And yeah, it was because they just couldn't get a good enough sample of the tumour.
Terrible. I mean, because you do see it takes a long time, you're waiting, and that example with 4 biopsies, I can't even imagine. That's pretty horrific stuff. Sure. I guess I also would like to ask a question, Prof. So with this new role of using liquid biopsies, what does that mean for the rest of it? Are we still going to do bronchoscopies? Are we still going to do all of this other stuff? And what happens if that comes back inconclusive? Because you talked about these tiny, tiny little fragments. Do you always see the fragments? Are you always going to get the right information in that blood sample?
Yeah, so you're quite right, Yvonne. So first off, you don't always get a result, okay? So if you do it in patients who have cancer that's spread throughout the body, so stage 4 lung cancer, it's about 80% of patients you will pick it up with present technologies. There are newer technologies coming through. We're never going to sit still. They're getting better and better and better. But using the present technologies, it's about 80%. You are less likely to pick it up in patients that only have disease in the lungs. The lungs are very good sponges. They don't release these tiny fragments of DNA. And less likely to pick it up if the cancer is only active in the brain, because again, the brain has a very different circulation. It doesn't have blood within it. But it's about 80% with stage 4 cancer. So one of the things people may wonder is if they've got an earlier stage cancer, should they be offered this test? And the short answer to that is no, it doesn't work with present technology. Okay, it's a waste of a test, it's a waste of your time. The other thing is that test gives me a lot of information that I need, potentially, okay? But it doesn't give me all the information I need. So, for example, it's important for patients in lung cancer, if you're not having a targeted treatment, to think about the role of immunotherapy. And that relies on the expression of a protein that some of your listeners may be aware of called PDL1, which shows how the cancer is interacting with the immune system. And ctDNA, liquid biopsy, will not tell me about that. Okay, so you still need the bronchoscopy to do that. And at present time, we are still carrying on the genomic analysis on the tumor, so we're still sending it off to the labs. In the future, so there's a couple of things to say. Is in the future, we may not need to do that. If you've already got the result, I've got a patient who I'm seeing tomorrow who I got the results at 4 o'clock this afternoon. I'm just going to start her on a treatment tomorrow. Great. And does she actually need the tumor analysis? Doesn't need it done. I'm already starting treatment. It's not making any difference. The other thing that we found in the pilot, and is actually a very useful use of this tool, is that lung cancer can affect people of any age, but actually does become more common as you get older. So the average age of lung cancer is 72 in England, and there's a significant number of patients who are 80 and over. And if you say to some of these people, not everyone, but some, if you said to you, you've got diagnosis of stage 4 lung cancer, we can offer you treatment, it's not going to be curable. A lot of them will say, well, I'd be happy to have a tablet, but I never want to have chemotherapy. I saw somebody 20 years ago have chemotherapy. It's not for me. And so what we have found is that with some patients, we've done the blood test, being able to say to them, look, you don't have a targeted option. I can't give you a tablet. Some of them I can give a tablet to, but most of them can't give a tablet to. And they're like, thank you very much. I feel reassured. I know I'm not missing out on anything. And I will now concentrate on spending the rest of my time with my family, doing things away from hospitals. And to me, that is an equally valid use of that test. In fact, it's very important use. And those patients may then not have a biopsy because we've already got the answer that they wanted.
That's a really interesting point, because I think it's giving back that control to the patient again, isn't it? It's allowing them to have the information that is required to then make that informed decision about how they want to proceed. And
Right.
that age-old debate about quality over quantity.
Correct. And so we found that when we looked back at our own data in the northeast of England, and we found that the patients who had liquid biopsies but not formal biopsies were older and were frailer. But we were still able to provide them with a test, and some of them went on to treatment, and some of them are under my care successfully having targeted treatment with tablets and feel very comfortable with that. Equally, some have not.
I was just going to think it must be a big blessing for those potentially who are older to have a blood test. Must be so much less invasive and easier than submitting themselves to these things. When I was having my CT guided biopsy of the lung, I was scheduled nice and early. I was a second patient, and I was in there like from 7:30 in the morning, and an older woman was going ahead of me, and her lung collapsed in the middle of that procedure. And it was really, it's a very dangerous, very difficult, challenging procedure as well. So the idea that we could potentially spare someone from going through that, it also caused terrible anxiety for me going second, thinking, oh my gosh, did someone have a bad night's sleep? And I'm second in this line. Should we reschedule?
Yeah, it is important to say, though, just to emphasize when we were talking about before, this is only about targeted treatments. So it won't rule out treatment with chemotherapy, and it won't rule out treatment with immunotherapy, which can work very well for some patients, older patients. But again, you actually need to be fit enough to have immunotherapy as well. So yeah, it is useful. I regard this as a tool. It's a very useful tool. It is not a panacea. It is not, it's not a magical potion or magical wand. And we have to be aware of that when there's lots of hype. I don't know if you saw the Daily Express front page, but I had my head in my hands. I do that relatively often when I see the Daily Express front page, but there you go.
Yeah, I mean, they love a sensationalized headline, don't they? Cancer cure on its way type thing. And no, I think, it is a tool, and the more tools we have in our fight against this disease, the more tools we have to diagnose it faster, the more tools we have to treat all the various different types of lung cancer. It's all heading in the right direction, and the momentum that is behind lung cancer at the moment, it's long overdue, but it's fantastic, and it really is pushing things forward in a way we just haven't seen before. And this is part of that progress. And even if the results come back and the person isn't eligible for targeted therapies, it's or they're not suitable to have the liquid biopsy, it's still a demonstration of all the hard work, all the progress, all the attention that lung cancer is now getting.
If you're unsure whether you can have a liquid biopsy, or if you have any questions or concerns about your diagnosis and treatment, we're here with the answers. Call our nurse-led helpline on 0800 358 7200 or email lungcancerhelp@roycastle.org.
The next thing I'm working hard on now is, this is easy for the patient, okay? It's not actually that easy for the doctor. These results are complicated. You have to learn how to interpret them. I reckon it takes at least 50 and probably more like 100 results before you feel comfortable. And even then, I get difficult ones where I have to call up, Professor Popat down in London, or he calls me up and we said, well, what do you make of that one? So it is a challenge. And it's also a new way of thinking about lung cancer. And as you say, I think that's for the better. But for example, learning how to use the biopsy to say, well, actually, there isn't something for targeted treatment here. I need to just crack on with chemotherapy and immunotherapy, and giving people permission that actually, the biopsy is going on in the background, but I already know a lot of the answers. I've already got a lot of information. I can start to plan the next steps. I don't need to wait another couple of weeks because, time is important.
Yeah, sorry, I'm pausing there because as you were talking, I thought of a question and I meant to write it down,
and
I didn't. And I'm of that age now where if I don't say it straight away, it goes out of my head. Yvonne, do you want to jump in and save me here?
Yeah, no. I think, look, such a interesting conversation, and good to talk about what it is and what it isn't. But I also think about like what's next, and because obviously our listeners, as we were discussing earlier, might already be diagnosed with cancer, but these blood biopsies could be useful in rebiopsy, right? And eventually we progress on our treatments, many of us, and you need to know what's that driver. So what about the role there?
Yeah, so the first thing to say is that is not funded in the NHS. So this, just to be very clear, this is only for people who have just been diagnosed, and in fact, it has to be done even before their first biopsy. There is a number of emerging uses, and we can talk about these going forward. This technology's got better and better, but one of the most obvious ones is, as you say, if you go on a targeted treatment, in general, the cancer will become resistant, unfortunately, at some period of time. And that is often by acquiring either another mutation in the original driver or acquiring another driver. And we're just now starting to do trials of trying to go after the other driver, okay? So, or adjusting the treatment appropriately. I would say mostly that is done within the research setting, and it can be very frustrating in my experience at present time, because you can do a liquid biopsy on a patient who's progressing on their targeted treatment. You can work out how they're becoming resistant to the treatment, but you may not have the appropriate study. That doesn't mean we shouldn't try. We just need to be aware of the limitations, both of the test, but also of what we can do with the information, either through the NHS, which is very limited, but even through trials, okay? Because sometimes there may be an appropriate trial, and there are trials going out through the UK trying to adjust people's treatment on the basis of it. But equally often I do it on a patient and I get the result back. And that's really disappointing. We've got a result, we know how the cancer is becoming resistant, and then I can't do anything about it. But as you said earlier, this shows the attention to detail. In the old days, we just used to give a tablet, and when it stopped working, we're like, oh, I'm sorry, that's it. Let's move on, think about moving on to chemotherapy. Now we're trying to learn how the individual person's cancer is becoming resistant to that treatment, and ideally adjusting treatment. And we are starting. And I think we'll see more of that over the next 5 or 10 years. I hope.
That will revolutionize if we can crack that, if we can understand why these target therapies stop working, then that makes potentially stage 4 lung cancer chronic illness that could be managed over a long period of time.
Yeah, I think for some patients it already is. We know that the average prognosis certainly for ALK lung cancer is extending. The EGFR mutant lung cancer, which is the most common form, it's extending as we get new treatments. We've just seen a trial present in one of the conferences in Paris, which showed the longest ever estimated survival in patients first presenting by using a new treatment. So, things continue to evolve. If I look at, I became a consultant 11 years ago, and the way I treat cancer now compared to then is just, it's chalk and cheese. It was much simpler in those days, but I actually think simplicity, cancer is unfortunately a disease that arises in your own body. And so to treat all lung cancers the same, that's got to be wrong. We know that's got to be wrong. I've already said we've got at least 200 different types of lung cancer, and that's before you even start to look at the changes in the genetics. So we have to treat everyone as an individual and their cancer as an individual. The problem with that is actually the research environment and the National Health Service isn't always set up particularly for this individualized structure of lung cancer. So, we have this body called NICE that look at whether treatments are cost effective for the healthcare services. And that's important. We're all taxpayers. Drugs are expensive. We want to get the maximum benefit. But if I've got somebody who's progressing in an individual way, on their targeted therapy as their second or third targeted therapy, how can we estimate for that individual the cost effectiveness of their drug? So I think we need to think about this differently, actually, as a healthcare system as well. And again, we are doing that. It is changing. But we need to get the regulators and the people who pay the bills to understand how quickly things are moving. And it's not just lung cancer, but lung cancer has been the sort of poster child of this approach, because we've started to learn more about lung cancer biology more quickly than we did things like pancreas cancer biology.
We keep mentioning kind of genetically mutated lung cancers. I think it would be useful if we just talk a little bit more about that, because I'm aware that some listeners might not know what that is. Mm-hmm. Would you be able to just give us a brief explanation of these types of lung cancers and the treatment? And Yvonne, you're living with one of these types of cancers as well, so feel free to jump in and share your experience too.
So the first thing to say is when people hear about genetics, they're worried that they've inherited something. Okay, and the first thing to say is, in general, it is very, very rare for lung cancer to be inherited, to the point I've probably only seen 1 or 2 in my 20-year career. Okay, so these are changes that are acquired due to our exposure to things in our environment, and we're starting to learn a little bit more about that. probably for a lot of these cancers, it used to traditionally be cigarette smoke and smoking. Now it's changing to other pollutants in our environment, but can be things like X-rays and other things. But the way I regard it, and the simplest one is EGFR, which is the most common type of non-smoking related lung cancer. And it's a switch on the outside of our cells in our lungs. And that should normally be switched on when we're a child and growing, or when we're recovering from surgery, but should be switched off. And this change switches it on. And then the cancer then uses that switch, that drive, as an accelerator to grow, to spread, to move throughout the body and do all the things that we don't want it to do. But in doing that, it actually becomes addicted to it. Okay, it needs that drive. It's a bit like sugar. Okay, and so what we do with our tablets is we block those switches. Okay, and by blocking the switch, because the cancer is addicted to it, you see cancer cells dying, you see shrinkage. Now, unfortunately, as we talked about, it doesn't tend to get rid of all the cancer cells. And to talk about why that is, we could spend hours doing it.
We need a much longer podcast.
And it's far from, but just to say that's how it works. And I will pass over to Yvonne as to how it feels like from a patient point of view, which is far more important.
No, thank you for that explanation. And for sure, I never even heard of these things, right? And had you shown me a list of diseases I might have had, lung cancer is the last one I would have picked. So being diagnosed with one was a surprise. Like, what does this mean? I had the exact same concerns you're talking about. And now in some of the advocacy work I do, I get asked for people, can my kids get this? Can I give it to someone else? And so that is a major concern, and it is confusing referring to them in that way. So it is in a way, I guess, if there is a silver lining in here, is that the treatment can be tolerable. And right, I mean, so I've now been on my treatment. It's coming up on 4 years, which is quite remarkable. I'm still on my first targeted therapy. It's an oral pill. I take it once a day. And it's, like I said, almost 4 years on and quite tolerable. I've returned to work. I've become involved in advocacy. I've returned to all the things I normally do, many of the things, not everything I can't run. There's certain things that now I do have instead. But I think it is quite hopeful in that it inhibits the cancer quite well. Obviously, we do see in our patient community that not everyone responds well, which is also disappointing when you have your long responders, your better responders, and we see them. You mentioned EGFR, same thing. Other oncogenes as well, like ROS1 and RET, where everyone has such individual responses, right? Even though we have the exact same mutation, you'd think we'd be more similar, but we're not. And that's hard when you're living in the community. Many of us make friends with other patients, and we're constantly seeing each one of us is having a different response. But the good news is there are these oral therapies. They work quite well. And I guess once we each run through the varying lines, we do have chemo in the background, and we just want to see the science continue to move forward to think about how do we keep, what you said there, Rachel, how do we turn this into a chronic condition, right? That's the dream. How can we live with this for many years and achieve a normal life? Yeah.
Can I just ask about kind of side effects? Because again, we've mentioned chemotherapy, and I think everyone has a very stark picture of what chemotherapy does. How have you tolerated kind of the side effects, or what side effects have you had through the targeted therapy?
So for me, I have to say, I feel really good on my targeted therapy. My biggest problem is sun sensitivity. It's extreme. I'm of Cuban descent, so you can hear my American accent. But I was born in America, I've been here 26 years, and I used to be a sun worshiper, and now I'm a sun dodger. And I guess in a way blessed I live in London, although, we have been having such sunny weather. So now we're big hats and wraps and all of that. So it is, and it sounds like silly, oh, it's only sunblock, but it's like a sunburn. It's like a chemical burn. It's like someone's thrown something on me, and it's so painful, it lasts for weeks. So that's pretty rough. Other people have different ones. Some people can have, gastric issues. Some people have exhaustion, weight gain. There's so many varying symptoms across the different pills. Each one of them come with their own gifts. And but look, on the plus side, we are living well. We're living when you think about where we're not on chemo, we all have that picture in the beginning. I remember saying to my oncologist I was going to go wig shopping because I thought I was going to have to do the classic and expectation. And then, even then when he told me the kind of chemo I was going to go on, it's actually like you were talking about, people think the chemo of 20 years ago. I think some chemos have changed. They're not all the same. But at the same time, I'm glad. I think there's also something mentally about going to the clinic to get an IV infusion every, whatever your frequency is, and just being at home, taking a pill, getting on with my day. It's pretty easy, and it doesn't feel that medicalized in a way. So it enables me just to feel a little bit normal, which I think helps you carry on.
And with side effects, that's what your clinical team's there for. Your lung nurse and your oncologist and all the people around you in your cancer crew. It's about minimizing and being able to manage those symptoms to the best that you can.
For sure. And I definitely had advice. In the beginning, it was confusing. I heard other people, and again, in the patient communities that I joined, everyone talked about sun sensitivity, just putting on higher sunblock. This is like next level. Blocks don't really do it. It's clothing and hats and gloves. It's just quite ridiculous in a way, but it's what works. And so I did see dermatologists. I did get advice, and it was important for me to do that. So I think that is absolutely right. Reaching out to your nurse specialist or your care team and getting that advice for any of these things that we are dealing with. And sometimes, I think people may not want to complain. They're afraid of being taken off their cancer treatment, right? What if the side effects are too much? And I think there's ways of managing them. So don't suffer in silence, and do get the care you need, because that quality of life is what helps you get out of bed every day and enjoy this precious time we all have.
I should tell you about my postcard wall.
Should. It'd be weird if you didn't, to be fair.
So when I was the first consultant and I started, so listen to these, we had relatively few tablets. And so it's one of my first patients I started on targeted treatment, and she was like, "Can I go on holiday?" And I said, "Of course you can go on holiday." And I made a joke. I said, "Send me a postcard." So she sent me a postcard. And so I put it up on my wall. And this lady, unfortunately, she's no longer with us because this was 10, 11 years ago, but she had a number of years of going on holiday. So I still have a whole notice board, which is just postcards from that one lady of all holidays she went on over that time.
It's a good point just to mention now that we have a podcast on getting travel insurance, because I think that's a whole other kettle of fish, issue for people living with particularly late stage lung cancer. So go and check that out. So that nice little plug there. Thanks for that one, Alastair.
Pleasure.
We now have so many ways to treat lung cancer, from robotic assisted surgery to targeted therapies. And whatever treatment you're on, we have easy to understand information to guide you through it every step of the way. Visit roycastle.org/information.
I remembered my question.
Excellent.
Told you it would come back to me. So when you were talking, you said it was quite difficult. It's easy for the patient, quite difficult for the doctors to potentially read. And you need to kind of get, did you say 100 before you start to feel familiar? Because of that, have you seen any kind of resistance from the community, the healthcare professional community, to kind of roll this out faster?
Yes. So I think those who have already engaged have seen the visible evidence for their patients. So I think there's a little bit of an adoption hump where people have to get used to it. So from a consultant's point of view, from a nurse's point of view, you not only have to take the blood, but you have to do the form, you have to package it all up. And that takes about 5-10 minutes. Okay. And you're saying, well, that's 5-10 minutes, but actually, given everything else we have to do, that's extra time. And mostly this is defaulted, unfortunately, to the lung nurses, who I'm sure you're all aware are very, very busy, run off their feet, and there's not enough of them. And then you get this email back, and it's about a 20-page PDF. file that comes back, and it's got the findings, the percentages of the various abnormalities in the blood. And Yvonne has been with us enough that she was able to spout off the abbreviations of EGFR and ROS and RET, which is, I think, most of us have become relatively comfortable with over. So there's about 7 or 8 of those 3 letters that everyone's comfortable with. And those are the 8 genes that we normally assess in the NHS. If we're doing this, we're looking at somewhere between 80 to 300 genes. So a lot of those 3-letter abbreviations people won't know what they mean. And they'll be, well, this one says 2.4% and this one says 1.6%. And what does that even mean? So that becomes very complicated. And so what we have done, Sanjay Popat and myself, is I've produced a very simple guide as to how to use the most common 25 genes. Okay, I'm not going to go from 8 to 300 because that's going to make people's brains explode. But even just simple 25, and we've just had permission for this for NHS England, and that's to help the doctors at least use the most 25 in a rational way. But we've also been very careful to try to set up support networks because people will feel uncomfortable about this. Okay, it's change. And I like change because I see that actually what we had 20 years ago was rubbish and what we have now is better. But change can feel uncomfortable, and particularly when people are stressed in a National Health Service, we're working in a stress system. We don't have enough time. We don't have enough money. Trying to have the headspace to deal with change can be very challenging. So yes, we are seeing people who are like, well, this is not part of my job. It's not what I trained in. It's not what I signed up to do. I trained up to do CT scans and bronchoscopies and CT guided biopsies. But I think the community is moving.
Good.
I also hope the patient message gets through because there is such a benefit to the patient. Like you said, it's easy for the patients and hard for those of you there. But the idea that you can find out what's happening when you're quite unwell and pretty terrified, it's exciting. I mean, it's wonderful to see that kind of progress, right? And it's important. So hopefully that message and just seeing like your patient got on something really quickly, that's got to be really exciting when, like you said, in the 11 years since you've been a consultant, you've seen lung cancer change. Those postcards are now on your wall in a way that they might not have been years ago, right? And that must be exciting.
Yeah. And the other thing from the chest doctor's point of view is actually for them, so it gives them something to do when, you've seen, again, it's giving hope to somebody. You're seeing somebody, it's often the first time you've met this person. And unfortunately, you have to say, you've got the CT scan up on the computer if the patient wants it. And you're saying, well, unfortunately, this does look like this is stage 4 cancer. We think it's probably coming from your lung. We need to get a biopsy to start to plan your treatment, et cetera, et cetera. And, you're on this sort of roller coaster of tests. It gives them something else to can say, well, yeah. And whilst we're doing all that, after we've had a chat, you're going to go away and have a chat with my lung nurse and, have a cry or swear, have a cup of tea. At the same time, we can take some blood off, and that's already going to the laboratory. We get the results back in 2 weeks. It's 2 weeks, pretty much consistently. And in the meantime, we'll be lining up the biopsy. We'll be talking to the cancer doctors about you, but we're already working on what your treatment plan is going to be.
And knowing that, and again, going back to what, I guess my father-in-law, we never had that. We never had the sense that things were happening in the background. It was all so dependent on that biopsy result to determine the treatment plan. So even just being told that, knowing that it's happening behind the scenes, we're getting ready, we're gearing up, that is reassuring.
Mm-hmm. Yeah. And this is not only the hope for the patient's first diagnosis, and we've talked about rebiopsy, but there's new uses coming through. So there's uses coming through for patients who have had surgery to help them decide whether they should have chemotherapy afterwards. There's uses where if you're on chemotherapy or immunotherapy, you can see earlier if the treatment's working or not. So this is going to change the whole way that we treat cancer, not just lung cancer, but obviously that's the most interesting cancer to us. So I think the next 5-10 years, we will see more and more of these technologies come forward. may even be used to detect cancer in the first place. There are screening studies and things like that. So, yeah, watch this space.
Absolutely. Just going back to, potentially a little bit of resistance, although obviously you said, hopefully people are starting to move with it. So back to the patient's point of view, how do they access liquid biopsy? Is it something that will automatically happen for them if they think it's a kind of a later stage cancer? Or is it something that they're going to have to really kind of advocate for themselves?
So the first thing to say is that this is only England, I'm afraid.
Yes.
Wales is doing a similar but slightly different program for a research program. Scotland and Northern Ireland have no provision. So if you are in Scotland and Northern Ireland, please do speak to your member of parliament and say, how come people in England and Wales can access this test, but not in Scotland or Northern Ireland? Because that is not fair. Okay. So the NHS England criteria are clear that it is patients who are fit, that have probable lung cancer on a scan and before their biopsy. Now, the earlier we do it, the better, because that's the earlier we get the result and start the treatment. Theoretically, all sites that are diagnosing lung cancer should be up and running and able to do this, but they will take time. It is a learning process. And if your site is not one of those sites yet, I think it is worthwhile asking. So a lot of patients, this will happen automatically. You'll come along, as I said, you'll see the chest doctor, they'll say you've got probable lung cancer, and they'll talk to you about having a blood test. And you may, if you're listening to this podcast, it may already have gone and be working through the system. If it's not, and if you've had the biopsy, unfortunately, in the NHS, that you're not now eligible for that particular test. We still hope, that will get results from your tumor and stuff like that, and we're hoping more users will come forward. But it is well worthwhile asking your doctor, why didn't you get this test? Because actually, maybe you should have, and it may not impact on you, but it may impact on you and the next patient 2-3 months down the line. They may not even have heard of it, or they may be resistant to it. And the patient voice is incredibly powerful. Okay. Me coming along and saying to them, oh, you really need to do this. They're just like, oh God, it's Professor Greystoke bashing on again about his liquid biopsy. But if a patient comes along and says, well, actually, this was important to me, I could have got on my treatment more quickly. And I understand it's too late for me, but maybe just think gently. Don't be aggressive about it, but maybe just have a chat to the person in the labs about how you can get this program working for you.
It's such an important point because, as you said, the NHS is under so much strain that there's already so much to do. But we need to remember to bring it back to why everyone's here, why we're doing what we're doing. And it's all about improving the diagnosis, the treatment, the care of people with lung cancer. That's what's important. And I think, yeah, absolutely. By doing that, it just reminds doctors who are under the cosh, under so much pressure, and we recognise that. But it's just that reminder of remember why you put yourself in under this much stress and pressure, why you wanted to be a doctor, you wanted to help, you wanted to care. And now we're having the tools to do that. So let's utilise them.
Yeah.
I think you've both said that so beautifully, because as a patient, that is what you want. And it's almost in the beginning when you're first having those scans, before you even get to the bronchoscopy, it's almost like an awareness campaign. People need to know that the next step after all those scans that you're having should be a blood biopsy before you, because it's a shame to have missed out, right? Once you have another form of biopsy, sorry, it's too late. And that's a tough pill to swallow in a way. Right.
Yeah, and that's not because we're being mean.
No.
It is being a little bit mean, but these tests are expensive. So the commercial cost for these, if you buy them from a company, which we used to do when we started this, now done on an NHS laboratory, is about £3,000 plus VAT. Okay. So, that's not an insignificant cost. And one of the things we were doing over the last 3 years and that we were working very hard at was to show that actually this is a cost-effective use of this technology for the NHS, because patients who have lung cancer are becoming more unwell, they're going in and out of hospital, they're having lots of scans, lots of biopsies. And if we can stop that, we can save the NHS money. And we showed that, okay? We showed that by doing this, you can save money if you do the blood biopsy early. The other way you could save money is if you did it late, if the initial tumor biopsy failed. What doesn't save money is if you do both the tumor and the liquid at the same time. That's very expensive. Okay, so that's why the rules have been set up. As I said, we're in a National Health Service. So yes, if you're in America, you probably would have a liquid biopsy and a tumor biopsy at the same time, but they've got a very different healthcare system for better or for worse.
And again, that's a whole other podcast.
Indeed.
I've just got one final question to you both. Obviously, our podcast is called Talk of Hope, and I'd love to hear what your kind of most positive advance that you've seen in your time as an oncologist, Professor Greystoke, and also Yvonne, in your experience so far, what's potentially surprised you with your diagnosis?
Okay, well, I'll go first, which is I'm going to cheat and do two, I'm afraid. Okay.
The fact that we've got two to choose, it's too hard a decision. We've got so much happening that you've got to pick two. That's a positive in my book.
No, I've got to treat two. So one is on the targeted side. So, and particularly based around ALK. So when I first became a consultant, we were just treating with the very first tablet that came through. Patients could only have it when they had already had chemotherapy. And we've now gone through the first, second, third generation, and we're about to go into the fourth generation of these tablets. So I have a patient under my care who was initially diagnosed with cancer before I became a consultant with brain metastasis, and had whole brain radiotherapy, which we don't often do, back over 10 years ago now. And she went from the first to the second and a half to the third generation ALK inhibitor. So she's been under my care coming up to 10 years now. Okay. And during that time, she's had grandchildren, she's lived a normal life. So that's, if you'd asked me in 2013 if somebody presenting with brain metastasis would still be alive and well and looking after their grandchildren in 2025, I would have called you a liar. So that's one. The second has been the immunotherapies, and we haven't really talked about these today because liquid biopsy doesn't really impact on those. But the ability to harness the immune system. So again, I've had patients who have been diagnosed with stage 4 lung cancer who I have actually now discharged from my care because they've finished their 2 years of treatment, whatever, their scans have been fine, and we've got bored of seeing each other. So I've sent them off to the nurse to look after and make sure that they're fine. And I concentrate on the more difficult patients. And every now and then, I get a little letter from the nurse saying, or sometimes I get Christmas cards from the patients, which is even better. I need a Christmas card.
Christmas.
Yeah, I need a thing. So two very different approaches to treat lung cancer. And actually both of them 11 years ago, when I became a consultant, were only just starting to emerge at that time.
Yeah, and I think, we've joked several times about that's another podcast, but I think immunotherapy is absolutely another podcast that we'd love to get you back on to dive into a little bit more. Yvonne, let's end with your element of hope.
Yeah, I think it's really related to the things you're talking about there, Professor, because it's all these advances that are happening, right? When I was diagnosed, I was absolutely terrified. I wouldn't make plans beyond 3 months. I had scans every 3 months, and I thought, I can't plan ahead. People would ask me, what are you doing in next June? I'm like, I have no idea. I'm not booking anything. I'm not doing anything. And now, seeing the research, seeing where the science is, seeing the continual advancements, I do feel I can plan, I can continue to continue with my life. And that really brings a lot of hope. So advances like this, just seeing the opportunity for today's people who are going to be diagnosed to have a quicker chance at getting on their treatment faster when they really need it, that brings me hope. Even though it doesn't impact me, I think I want the next group of people coming in there to have a better chance. And then seeing those of us that have already been diagnosed, there's continual advancements. And that really is exciting when you see new therapies, second gen, third gen, et cetera, continuing on all these complicated things that happen at these different cancer conferences. It's exciting to see them happening. So I think for all of us, look, we have to continue looking to the future, obviously be empowered with information. I do think that's important for all of us, right? How can we truly arm ourselves? Like you said, Professor, it's so difficult for treating oncologists, right? There's so many options out there. And if you're not under a lung specialist, I can only imagine what, 200 lung cancers alone, right? How would you deal with if you're treating every cancer under the sun? So I think I would just say to anyone else who's fighting this disease, it's not always easy, but it really makes sense to empower yourself if you don't want to do it yourself, because it can be triggering. And I completely get that. I think get a loved one, a friend, a family member to help do it for you, because I do think participating in that shared care is really important for us. And just seeing what's out there today, it's complicated, and let's help make sure we're helping to look after our own care team, our own care.
It is complicated, but it's complicated now in a good way. You said earlier that it was simpler to treat lung cancer 11 years ago because the options were so limited. So let's be grateful for those complications. It's been a pleasure, Yvonne. Again, thank you so much for stepping in. Mandy's going to feel a little bit jealous because clearly, we've bonded. I think it's wonderful, and we'd love to have you back on. And Alastair, thank you so much. You've really explained it. I am not a medic, and it's you've explained it in such a clear way, and I'm sure people listening will find it really useful if they're going through that potential diagnosis. And as Yvonne said, even if it's not applicable to them right now, it's another demonstration of the progress that we are all making in this fight against lung cancer. So thank you very much.
Thank you. It's been a pleasure joining you both.
You have been listening to Talk of Hope from Roy Castle Lung Cancer Foundation. For support and advice about any of the topics covered in this podcast, visit roycastle.org. Talk of Hope is a fortnightly podcast with new episodes released every other Tuesday. Like and subscribe to make sure you never miss an episode.